Before I get started, I just want to say something about this conclave. When the idea was brought to me by Nishant, where is he? Okay, there. I actually didn't understand what this was all about. And quite frankly, Nishant, I still don't. But the more I see of it, the more I understand of it, the more I love it, okay? I mean, as a sports injury specialist, and that's what I like to think of myself, I thought that I knew my field. And today, I have learned so much from Swati, Ali Irani, you name it. There is no end to it, and I like to think now that I'm only in a tunnel zone where I'm looking at my perspective, which in fact is true because patients are sent to me after everything has been done. Patients have been trained, they have been given the nutrition, they have played the games, they have injured themselves, and the injury could not have been treated by conservative methods by the physiotherapists and other people. So then I get saddled, and then I think that, oh, I'm the specialist, and I know everything which I now know I don't. So it was slightly difficult for me preparing for this talk, because it would be much easier for me to talk to orthopedic surgeons, because then I'd go into the details of surgery, and that would be my zone. But I know that the spectrum of people we have got over here is very different. And people who have got personal experiences, who've treated themselves, people like Balaji, who've not only treated themselves, but have other people treat them, and a whole load of other people who are in the process of looking after others. So before I get started, can I request all of you to stand up on your feet, please? Okay. Raise your arms, stretch yourselves, give yourselves a good stretch. The next thing you do is turn to the person who's standing next to you, whichever one, right or left, it doesn't matter. And Varun, you can stop dancing. You can make up your mind which way you're going. And with all sincerity, that person is standing next to you. And in all sincerity, say to the person, I love you. Well done. Okay, guys, sit down now. This is where I work. This is my NHS base, Sandwell General Hospital. And the reason why I selected this picture to present to you guys is because it's a typical English day, wet. You can see the water on the grounds, and there is no escaping from that. We are in the process of moving over to another hospital, which is going to be spanking new. Sorry. But just to show you a layout, it's a huge hospital. It's one of the major hospitals of Birmingham. So what is the prevalence of knee injury? Now, I looked around at lots of papers, and I selected this one because in 10 years, they actually looked at 6.6 million people attending the A&E department, which is the Accident and Emergency Department. And it looked at all sorts of injuries, and 49, which is about 50% of the presentation to the A&E department for knee injuries was from sports. The others would obviously be cuts, bruises, fall down the stairs, and things like that. So sports is huge when it comes to knee injuries. Then I started to look into the sports bit of it, and there's another 10-year study in which they have looked at about 18,000 patients. And of the sports injuries, the knees comprise about 40%. And this included everybody, like running on tracks, twisting your knee while playing tennis, tackled in rugby, all sorts of kind of things. So we can't escape the fact that knee injury is common in general population, and knee injury is very common in sports people. So where do we start to look at? I mean, what's the breakdown of this? So men are more likely to get knee injuries in sports, and the majority will be in their 20s. Competitive sports will be the highest, as you would expect. And interestingly, what I found was that about 2/3 were non-contact sports. That includes badminton, tennis, cricket, and the likes, and track and field events. So just to re-emphasize the point that the knee is the most complex joint in the body. It's got lots of ligaments that stabilize the knee joint. It's got 2 different types of cartilages. Now, with regards to the ligaments, what I like to tell my registrars is that think of a swing. You got 4 ropes in the 4 corners, and that stabilizes the swing. Likewise, knee has got 4 ligaments, 2 on the sides, 2 on the inside, which are the cruciate ligaments. And if any one of the ropes of the swing goes, the swing becomes unbalanced. So the ligaments are critical. If 2 ligaments go, then the knee is gone. The patient can't even walk. So what about the other structures around the knee? What you can't forget is that the nature has created something to cushion the different parts which you are putting stress on. And to simplify things, we call it bursae, which is like a sack full of fluid, which acts as a cushion, like the airbag in a car. So the nature is trying to protect that particular part of the joint. And in the front, you can see that you've got 3, one above the patella, the kneecap, the other one is below, and one directly in front. But a very important one is sitting at the bottom left over there, which is the Pes Anserine Bursa, which people quite often tend to ignore. Gerhard, do you come across that very often? Not very often. But you do get patients who have got pain on the inside of the knee at the top. I see them very often. Now, if you look at the knee from the side, you see that there are bursae not only in the front, but they are also behind, and they can be also behind the patellar tendon. Now, for your sake, I broke down the persisting pain. Now, can I also remind you that I'm talking about persisting pain. I'm not talking about swelling in the knee joint. I'm not talking about the knee giving way under you. I'm not talking about any other mechanical symptoms like locking of the joint. I'm just talking about persisting pain. So to break it down, to make it easy for you guys to understand, I thought I'd break it down into intra-articular and extra-articular. So extra-articular would mean outside the joint capsule, including the capsule, and the other one would be what's inside the joint itself. So extra-articular, the things that I've already mentioned, they include the tendons, which run at the back and the front, the ligaments, which I've told you about, the bursae, which I've told you about, the periosteum. Quite often people get pain down the front of the leg, which for layman person, in England, it's called the shin splints. I don't know what we call it over here. So that cannot be ignored where it comes to extra-articular persistent pain. And for intra-articular, I'll run down these things later on as well. But meniscus is one of the crescentic cartilages inside the knee, one on the inside, one on the outside. Then you've got the actual articular cartilage itself, the cartilage that lines the joint. And people talk about softening of the cartilage, the chondromalacia patellae, that kind of stuff. Rajat Bhatia was talking to me about it this morning. Fat pad, fat is present inside the joint. And you also have got bands of tissue, which I'll talk about later on. So when you get a patient who's radiologically negative, now I'm talking about patients who've been examined and been sent for x-rays, which did not show any abnormality, MRI scan, which did not show any abnormality, and maybe even ultrasound scan. So the person who's treating them, the physiotherapist, has got no clue what he's dealing with, unless, of course, he's done a very good examination of the patient, taken a good history. So what I go back to is the history and the mechanism. When did it start? Did it start after a prolonged period of bowling action or playing badminton, and gradually it's been progressing? Or did it come when they fell down the stairs or something else happened? I mean, you see lots of, on television, lots of videos of bowlers running up to bowl, and when they land, something gives, and they fall down, and after they hobble off the pitch. Now, that is critical when it comes to a diagnosis. So the mechanism, the actual history, then I look at if the pain is persisting, what actually makes it worse, or what makes it better. And the person who's suffering the pain actually understands that much better than anyone else ever will. Of course, I get down to examining, and sometimes, only sometimes, we've got to go for diagnostic injection to actually numb a certain area to see whether numbing that part takes the pain away or not, or is it being referred from somewhere else. So all these things are there in helping you come to a diagnosis. So when it comes to tendon, ligament, and periosteum injuries, I know the physiotherapists know it only too well, and I'm sure most of you know it as well, that you've got to go through the full spectrum of it. Now, what do you do with physiotherapy? I'm sure you do stretches, deep friction, ultrasound treatment, acupuncture. Anything else anybody would want to add to that? Anything else? Normally with physiotherapy, you sometimes, I know you sometimes do inject a little bit, isn't it? Yeah, I'll come to that later on. So this is something else I start off with, which is non-invasive when I get passed a patient by the physiotherapist. Say, right, okay, I've made a diagnosis. Maybe it's an inflammation of the tendon or a ligament or periosteum or whatever. ESWT, which is extracorporeal shockwave treatment. It's very similar to what was created for breaking up the kidney stones, the lithotripsy. The difference is that in lithotripsy, what they were doing was they were focusing the shock waves from sides so that it came to a pinpoint, and that would shatter the stones. Whereas in this one, it's just the opposite. So it spread a little bit so that it dissipates the edema and creates an anti-inflammatory environment. And with that stimulation, cytokines are released. I normally give 3 sessions, which comprises of about 2,500 to 3,000 cycles, and they're given 1 week apart normally. It can be a little uncomfortable, especially if it's given near a bone. So be aware of that. I quite often tell my patients to take a couple of painkillers an hour before they come and get the treatment from me. You know, that kind of makes me feel better, and the patient feels slightly better about me because he said, you've hurt me less today. Great. So that works. The success rate is pretty high, given that it is completely non-invasive and non-specific. It is just treating inflammation and irritation of a part of the body, 60 to 80%. And what I've found is that after the 3rd session, and after the 3rd session, I actually tell my patients, sportsmen or general population, not to do too much for the next 3 weeks, and to use plenty of ice to calm the tissues down and start to train after that. And I found that within 6 weeks, most of them are actually ready to return to work, which is very good. And the most important thing is it is safe. I do not know of any adverse feature that is associated with that, except pain or discomfort. Especially if the person is a wimp, then he'll complain a bit more. Steroids. Now, the steroids that we've been talking about earlier on today, they've been about anabolic steroids. These are not anabolic steroids. I am talking about methylprednisolone, which are only locally acting, and which is what the physios often give to the patients, whether it's spokesperson or whoever else they're treating. It is quite predictable. It's quite predictable, and it is fast-acting because quite often you mix it up with a bit of local anesthetic. So within 2 minutes of the injection, the person will say, it feels a bit better. I tell them, well, don't worry about this. It's going to go away, and you're going to be in more pain after about 6 or 8 hours than you are in now, or where you came in with. But obviously, it has got to be used very judiciously. It has got its known complications. Infection is something that I worry about all the time. It can cause tendon rupture, especially if the injection has not been given properly. It should never be injected inside a tendon. It's meant to be put under the tendon sheath, but that's very difficult to identify quite often. It's safer to inject around the tendon than in the tendon because you could actually do the patient irreparable harm. And of course, in high doses and repeated injections, it can cause osteonecrosis, which is the bone in different parts of your body can actually die, and that's a disaster. But there are lots of patients who get steroid injected inside the knee joints or other joints. And there's a very large paper recently that was done in Boston, USA, and that showed that it was a radiology paper. They showed that after repeated injections of steroid, the volume of the cartilage inside the joint has actually deteriorated more rapidly than a normal population. And that has woken me up and woken up lots of people who till now used to feel that it was a fairly safe thing to do and give 3 injections in a year, and you can do it for 3-4 years in a row. I would be very, very worried about it. So moving away from there, PRP is a recent baby that I've adopted. And there are different ways of doing it, and different people have got different companies with different machinery, and they say, right, okay, 1 big dose, and some people say 47 doses, you know, all that kind of thing. The one that I've gone for is from a company that has actually researched their injections, and it's been published in peer-reviewed journals. And I take only 15 mils of blood from the patient. Before the injection, I tell the patient to drink plenty of water. Take the blood, mix it with nothing, absolutely nothing. Spin it in front of the patient and take only about 4 mils, anything between 3 and 5 mils from that spun blood. And I actually show it to the patient. Look, this is your PRP, which is platelet-rich plasma. Now, that plasma that you take is got, as the name suggests, very high concentration of platelets, which has got, again, a very, very high concentration of growth factors. Okay, so this growth factor is a non-specific, but a general kind of a thing, and it is not a harmful thing because it is part of your own blood. So you have not put any chemical into it. I've used it extra-articularly, and I've had patients. I don't only treat sports people, I treat other people as well. So I've had people who started to have pain at the age of 45 and say, right, okay, my knee is beginning to creak, and I've got somebody sitting over here who's been talking to me about his knee as well, but I didn't recommend PRP to him. But every patient I've given to, every single patient I've given to, comes back for the second injection, which is normally about a week or 2 weeks after the first one, and tells me, you know what, doc, it feels a bit more lubricated. And when the first 2-3 patients did that, I said, what? Lubricated? And funnily, they were all separate patients, not talking to each other, but the word lubrication was the word they used for me. So somehow, it just makes it feel better. For me, it is a very safe thing to do because you're not giving any chemical into anyone. My protocol is to give 3 injections between 1 and 2 weeks apart, and I think they work, okay? So bear that in mind for patients who have got persistent pain and soft tissue, which is especially extra-articular. There are lots of growth factors which are enumerated over here, which I've got no intentions of going into. So, periostitis, how many of you have actually heard of this expression? Can I have a show of hands? You have, yeah? You? Okay. Just a sprinkle of you guys. It is very common in Army personnel. And my interest in sports injury actually came from the Army side because for some crazy reason, I joined the British Army. And I was in the RAMC, and I've done deployments in Bosnia, Sierra Leone, and Iraq. I've treated war victims, and I've had patients come to my operating table with brain coming out of their ears, okay? So really horrific injuries. Head of the femur inside the pelvis. So, you know, I've seen some very horrific ones. But the one thing common between Army personnel and sports injury is that they're all very high demand, but also they are very highly motivated. They're very highly motivated. They want to get fit. On a side note, the one person I treated in Iraq was a young soldier. I think he was Lance Corporal, somebody, I can't remember. These guys are such maniacs. They want to get physically fit. They want to go out with guns blazing. They want to get things right all over the world. Apart from working out in the gym, what this guy was doing was he picked up a huge, big block of concrete that had been lying over there from a construction site, and he started to do curls on the road, and the block slipped from his hands, and it landed on his foot, and it took all the toes off. And when I went to see him, when I told him that for all practical purposes his army career was over, I could see tears welling up in his eyes. I pulled the curtains, ordered everybody out, leave this guy in peace for 10 minutes, let him cry. Okay, but anyway, that was just a side note. So coming back to periostitis, when I get patients with periostitis, the first thing I do is, as has been mentioned before by the trainers, that look at the shoes. Are they wearing the proper shoes or not? Because quite often, army personnel and sports people don't wear proper shoes, and they put far too much impact on the shin bones, on the tibia, and that leads to a bit of stripping of the periosteum, which obviously the first line of treatment would be physiotherapy, including heat and cold and everything else. But here's somewhere where injections and other things are not going to work. So stripping, periosteal stripping, which is a very simple operation, that'll do the job. So now coming to my babies, my personal babies, which are the intra-articular problems, because that's when I start to take out my knife, sharpen it, and say, right, okay, get on the table, and I'll plunge it in you. So there are a whole load of structures over here that I do look after and I do address. And this is not just a number game. It is something that I do all the time. Now, okay, meniscus. Are you guys familiar with the meniscus, the cartilage, the crescentic cartilage? Show of hands again. Okay, again, not very many. Now, what nature has done is, it has tried to help us, because from being on all four, we decided to get up, stand on our feet, and walk on two legs. Now, the top of the tibia is kind of flat, okay? And the bottom end of the femur is kind of round. So it's like trying to balance a ball on a flat surface. So that was going to be difficult. So what Lord Almighty did was, he put in a wedge-shaped crescentic thing on each side. So it became like a shallow dish, and the ball was being balanced in the shallow dish. And that's better than ball being balanced on a flat surface. But because this little piece of cartilage is an extra piece of cartilage, it is only very loosely attached to the joint capsule and not at all to the bone. So it can move around, and it can get trapped, and it can tear. So meniscal tear is very common, but the one that I'm talking about is red on red, or detachment of the meniscus from the capsule, because these are the ones that will be radiologically negative. And that is the topic I'm talking on. I'm not talking about all persistent knee pain, only those for which investigations don't show up anything. So quite often, you get a very peripheral tear, a small tear, which is not responding to anything. You can't see anything on the X-rays or the MRI scan, or there might be an incomplete tear. So just to give you an example, now that's one of my probes, and this is the meniscus. Right at the edge of the meniscus, you can see some fluffiness, and that actually is a tear. So I put a hook over there, and you can see that the other places, I can't put the hook inside, but over there I can. That was the cause of persistent pain, and it was an athlete. So what did I do? All I had to do was put one stitch over there. One stitch to close the gap after I had freshened it up. That treats the condition. That makes the person back to feeling normal so that he can get on with his life. And the outcome, normally the outcome would be taken as very good as a general rule, but I did some personal studies on this, and I found that if a person has a tear like that under the age of 21, then the healing is almost 100%. So if you've got a young person, and my patients range from, I think it was from 14 to 21, that particular age group. And it was presented at the World Congress of ICRS, which is International Cartilage Regeneration Society in Italy. And that is very encouraging, but I have done repairs right up to the age of 60. And even in the 50s, it actually works quite well. So I would give it a chance rather than take the cartilage out. Now, this is another one where it's an incomplete tear, and I couldn't put the probe from above. But when I went from below, this is another meniscus, and just go along with me. That's my probe, my hook, which I'm tugging that way. And it's showing kind of an abnormal movement over there. Okay, and another 2 stitches over there. Again, from above downwards, taking the full thickness, went inside, did the job. So, once I've done the repair, what do I do post-operatively? I protect the knee for about 3 weeks. And how do I protect it? You've got to remember that the posterior condyle is much bigger than the distal condyle. So I don't want my patients to bend the knee too much. So keep the knee in a splint for about 3 weeks. They don't have to keep it all the time. I don't put them in a plaster ever. The reason why I put them in a splint is because they can at least go and have a shower if they wanted to. If they're sitting down watching television, they can take it off, get some fresh air onto the leg. So it's a general good feel is there. And non-weight bearing or touch weight bearing with crutches. Because again, I don't want the meniscus that I've repaired to be squashed between the femur and the tibia. The average return to sports after the repair is 4 months, which is pretty good, given that they would have had at least 3 or 4 months before they actually came to me. And excellent outcome for the right cases, and obviously, with any procedure, you go to the right job the right way. Now, sorry. Now, the next bit. So, you know, the second bit is the cartilage that actually lines the joint. Any damage to that is broadly or roughly referred to as arthritis. I mean, it doesn't always come into the category of arthritis, but what happens is that, for example, if a bowler has landed heavily on the leg and twisted in the bowling action, there's a huge amount of torsion that goes on while the patient is bearing weight. And it can lead to either incomplete or full thickness. And normally, as I said, it's associated with some kind of a torsion injury. So you might be interested, Jonty, that many of your colleagues, less illustrious than you, have had something like this, where everything else looks perfect. You know, that's the top of the tibia. That looks perfect. The meniscus is perfect, but he's damaged the articular surface of the femoral condyle. Okay? And that will not show up on an MRI scan or an X-ray. It will not. So it's particularly important for people who are not playing chess, but playing other sports. This is another example. And I think, Gerard, this is an example of one of your bowlers from a few years ago. And he had actually stopped playing cricket. He'd stopped bowling. And this is what I found, because everything else was absolutely fine. Another example of a different case where is a deeper tear, thicker amount of cartilage taken off. But also, as I said earlier on, just look at the meniscus, looking beautiful. The articular surface on the tibia is looking beautiful, but he's just ripped off a little bit of the articular surface. So what do I do to that? I can either do a mechanical resection, which I don't like. I do radiofrequency. I tell my patients it's like a welding tool. So I weld the cartilage, the torn portion, back. Obviously, the defect will be there. I can't do anything about it. But the free edge of the tear will be repaired. And now, just to give you an idea of what it would look like after I have done the radiofrequency. So I have smoothened it out. The defect is still there. But I think your bowler went back to playing cricket, bowling the same year. And I think the year after, he was probably the most successful bowler in the county circuit. So it made a career-defining change. Simple procedure, okay? But you've got to be able to identify the problem. This is another one where there is a bigger area of defect. I can't remember who this patient was. So the immediate problem is taken care of, but the defect is there. And you've got to be aware, you've got to tell the patient, you've got to tell your spokesperson that they cannot ignore it for the rest of their lives. Maybe carry on for another 4 or 5 years, but at some stage, I would recommend that they should have cartilage regenerative surgery, because nowadays we don't talk only about treating the present problem, but we're also looking at the patient's future. And I was mentioning that to you yesterday, that we actually grow cartilage in the knee now. So we are doing that, and what I've shown you, it's something that is likely to be required. Now, what happens when there is a full thickness tear? The previous pictures were those of where there was still some cartilage left. Over here, you can see that my probe is sitting on bone over there. And everything else, again, looks pretty good. And if you, in the same patient, that piece of cartilage that had come off from the femur was lying under the patella, under the kneecap. And again, when I was going to fish for it, it floated away into the suprapatellar pouch, took it out, put it on a swab. This is what it looked like. And I said, can't do anything with this one. I can't glue it back to the bone. So what I would have to do is go for further surgery at some point. At that point of time, I would still use the radiofrequency to weld around the edges so that what I tell my patients is that any tear in the cartilage is like peeling off an orange. If you don't take off the loose portion, and if you don't stabilize the edges, the orange peel will keep on ripping further and further, okay? So non-surgical treatment is not likely to work. I stabilize it at that setting with the radiofrequency. And the cartilage regenerative surgery, which I was talking to earlier on about, it's ACI, MACI, that is a 2-stage. Just to give you a flavor of the things that we are doing now for the sportsmen and other people as well, is we actually take a piece of cartilage from the patient's knee, grow it in a lab. So the patient's own cells are growing in a lab. At a second operation, we put these cells back into the area of defect, and the results are amazing, okay? But that's a 2-stage operation. This is my latest surgery, which I'm doing now. It is a 1-stage where I actually don't take the cartilage and send it to a lab. I just prepare the area of damage, patch it up with a collagen that will receive the cells from coming in from the inside, and I supplement it with bone marrow stem cells. So we actually aspirate the bone marrow, create stem cells from there, tag it to the collagen that I have put over there. Excellent results. And it's a 1-stage, and it doesn't destroy any part of your knee. The Oates procedure is just for completeness. It is taking out bits of bone and cartilage, plugs of bone and cartilage from one part and transferring it to another place. Don't like it? Very good. It's all right, but not the one that I would be going for very easily. So, moving away from the cartilages now, simpler stuff, which again are difficult to be picked up on X-rays and MRI scan. There are lots of plicae, which is bands of tissue that people are normally born with. There are different plicae, different ones, but the most important one is the medial plica. And just to show you an example, you can see it on an MRI scan, just like a little band of something that's coming on from the side, but don't be fooled by it. It's a very hard, very thick piece of tissue. You don't always see this, and this bit that is curling over here, swinging round, it's sitting between the patella and the lower end of the femur, and this can work as a knife. It can actually cut through the joint cartilage and take the cartilage off. The patient will continue to have pain. There might not be any history of any injury or anything else that's causing it, but it is something that is a real problem. I've seen patients with complete cartilage taken off. The simple thing is, do an arthroscopy, snip it. It's like, you've got a bowstring which is tight. If you snap it, it just springs away. Simple. It's diagnosing it. So like I said, it's very difficult to diagnose. There are no clinical tests that will actually identify it. Can erode through the full thickness of the cartilage. And if the plica is such that you are able to feel it, it'll give you a hint about the diagnosis, but not always. You can try massages and injections, but if they don't work, then I think you've got to go for surgery. You can do all this. Arthroscopy is the gold standard because you don't normally fail with that one. And now the fat pad impingement. This is a normal fat pad that sits behind the patellar tendon, and it can get trapped. It can either get trapped just below where the lower pole of the patella is, or it can get trapped over here, if the slide will change. Yeah, so it can get trapped over there. And the simple solution would be, before I come to the solution, deep flexion can be painful. Patellar grind may be positive if you're actually squashing the fat pad, but there'll be no other thing to find. And physio is unlikely to help because the fat pad is actually getting physically caught. Ice may help. You can try injections. As usual, it may or may not work. And again, arthroscopic resection, the patients often come back and say, Mr. Prakash, why did you not do it before? Why did you wait for so long? I said, I want to try non-operative treatment for you first. So the summary is that the knee is the most complex joint in the body with lots of structures, and then there can be lots of pathologies in and around it that will be difficult to identify. Be aware of the different areas. So history, mechanism, and clinical examination are of utmost importance, especially if the X-rays, MRI scan, and the ultrasound scans are normal. You can use anything, right from ice to surgery, to treat the different problems. There is no guru mantra, just a simple, one tablet is not going to cure everything. And if you're not progressing, you should know when to ask for help. So you don't have to wait for the truck to go into the ditch before you ask for help. Even when it is sliding, try and see if there's somebody who can help you. So what are sports people like? They're high performance. I'm a bloke, I'm a typical bloke. I love cars. At the moment, I don't drive a German, I drive an Italian, but I love BMWs, so just likened the sports people to BMWs. High performance, they're high demand. BMWs are not easy to maintain. But you trust them, you respect them, and you love them as well. I love my BMWs, and I love my sports people who come to me. And they will drive. I mean, if you look after them, they'll drive like all BMWs or all machines with a BMW logo. Like this. Thank you very much.